Okay. All right. Good Friday afternoon, everyone, and thank you for joining us. It is my pleasure to introduce our speaker today, Dr. TK Susheel Kumar. Dr. Kumar is an associate professor in the Department of Cardiothoracic Surgery at NYU Grossman School of Medicine and serves as the director of the Pediatric Heart Transplant Program at NYU Langone Health. He specializes in pediatric and adult congenital cardiothoracic surgery. Dr. Kumar's clinical work focuses on the treatment of complex structural heart defects, heart failure related to congenital heart disease, and advanced therapies including mechanical circulatory support and heart transplantation. His training includes fellowships at Children's National Medical Center and the University of Michigan. He is board certified in pediatric and adult cardiothoracic surgery and has contributed extensively to the field of pediatric cardiothoracic surgery with over 100 peer-reviewed publications and presentations at both national and international conferences. Beyond his technical expertise, Dr. Kumar is deeply committed to medical student education, and we have the privilege of having him here today to speak to us about the Fontan procedure. Please join me in the Thoracic Surgery Medical Student Association in welcoming Dr. Kumar.
Thank you, Ahmed. I just hope that everybody can hear me well. And if you can't, feel free to stop me in between. Okay, Ahmed? Also, make sure that you can see the slides as I start commenting on them. So, first of all, I want to thank you for the kind words. Thank you for the invitation. Yes, I do enjoy what I do, but I also enjoy teaching students and building doctors for the future. We can't do this forever. So, so I'm going to talk today on a topic I think that's more fundamental. When I was approached by the students, I told them that I want to talk on a topic that will enhance your understanding rather than getting into the nits and grits of cardiac surgery, that you can do at a later stage of the game. But the important thing to understand the concepts of operations, why we do them, when do we do them, and why do we do them the way we do it. So today we will focus on management of single ventricle, and then that will take us to shunt, Glenn, Fontan, and failing Fontan, and you will understand the rationale of the different operations and also the mechanisms of failure. So, what is single ventricle? Basically, when you talk of a single ventricle, um, you can think of two different situations, right? You can have a single ventricle when you have anatomically just one single ventricle. So what is called as a common ventricle. The entire ventricular septum is missing. But you can also have a single ventricle physiology when patients have two anatomical ventricles, but there is problem with either, say, the AV valves or the semilunar valves, or they're just not routable. So, in fact, having an anatomically single ventricle is rarer than when you have ventricles that are inadequate size. We'll get into the complexity and the details of this as we talk. So, but the important thing to understand here in this picture here is that look at the picture on your left. Here is a normal circulation, right, where the blood that enters the pulmonary artery from the SVC and IVC is all deoxygenated, goes into the lungs, gets purified, and comes back as red blood or oxygenated blood into the left ventricle. So the blood entering the pulmonary artery is blue, but the one that's entering the aorta is red. But look at the patient, look at the diagram on the right side now. Here you can see that there is mixing of blood, and that can happen either at the atrial level or at the ventricular level, depending upon the type of single ventricle anatomy. But the important point here to observe is that the oxygen saturation of the blood entering the pulmonary artery is identical to the oxygen saturation of the blood entering the aorta. Does it make sense? So that really is the essence of single ventricle. Now, which is one has to, once again, just at the expense of repetition, is different from a normal 2B circulation, where the blood entering the pulmonary artery system has a different oxygen saturation than the one entering the aorta. Here, both are the same. That's fundamental, and keep that in mind as we talk along. So many terms have been used for single ventricles in the past, single ventricle, core bilocular, common ventricle, etc. But the term that is probably the most scientifically sound is to use the term functional single ventricle, which means that this is to cover all those hearts that have two pumping chambers, but essentially work as single ventricle because of anatomical issues. I will give you examples of that. Okay. So true solitary ventricles, as I mentioned, are exceedingly rare. Now we'll just get into a few of the morphological subtypes so that you are all familiar what the terms mean. It is not meant to be a comprehensive coverage, but we will just talk about, say, some of the most common subtypes. You can have what are called as double inlet connections, AV connections, say DILV or DIRV. DILV is far more common, wherein both the AV valves are opening into one ventricle. Okay, I'll show you examples of that. Then you can have absence of one of the AV valve connection. Classic example is tricuspid atresia. Then you can have common AV valve and one ventricle which is underdeveloped. For example, extremely unbalanced AV canal defects. Then you can have single ventricle heterotaxis syndrome. And then, of course, you can have hypoplastic left heart syndrome, which is, the most glaring example of single ventricle that we operate and manage these days. So let's start with tricuspid atresia. So in tricuspid atresia, here is the picture that demonstrates the anatomy of a typical tricuspid atresia situation. You can see that here the tricuspid valve has completely failed to develop. So what happens is that the blue blood entering the right atrium has no choice but to cross the atrial septal defect and mix with the oxygenated blood coming through the pulmonary veins. So the mixing in this case happens at the atrial level, and then the mixed blood goes into the, you can see here getting into the aorta, and then it also gets into the pulmonary artery. So this is an example of where one of the AV valves has failed to develop, correct? Now, what about double inlet left ventricle? I spoke about double inlet situations where DLV is the most common one. You can see here what happens here is both the mitral and the tricuspid valves are emptying into one ventricle. So in embryology, we often use the phrase no flow, no grow. It's quite popular. So during fetal development, if all the blood is coming into one ventricle, what happens is that that ventricle grows, but the ventricular chamber that does not receive any blood flow will not grow. Okay. And we also see this, say, we apply this sort of principle for operations and sort of dictates the timing of operations in many of our neonates because we know that ability to grow with volume lasts for up to a few months to years early on in life. So it's the same principle in TILV where the LV has grown, but the RV is more like an outlet chamber. And so this patient is another classic example of single ventricle. Then you can have unbalanced common AV valve. You can see here it's a complete AV valve, but one of the ventricles, in this case, the right ventricle is smaller. And when it becomes an extreme form, that ventricle is not usable. So basically, you are left with a single pumping chamber. Then the fourth example is hypoplastic left heart syndrome, right? You can think of this as more like the same sort of problem that caused the tricuspid atresia, now affecting the mitral valve, right? So again, because there is no flow, no grow, if you apply the theory, there is not much flow across this mitral valve. So the LV fails to develop. LV is very small, and then the aorta is very small, right? So you can have various subtypes depending upon the degree of development of the mitral and aortic valves. You can have MS, AA, MAAA, on mitral stenosis, aortic stenosis, etc. But the fundamental thing is that here the LV is too small to handle the entire cardiac output by itself, correct? So then this gives, observe the anatomy, this gives rise to a small diminutive aorta, and it's the most of the blood that's coming into the left crosses the right, opposite of what happens in tricuspid atresia, mixes up, and here RV has taken over the function, and this pumps blood across into the descending thoracic aorta, retrograde across the transverse arch, but also is pumping blood into the pulmonary arteries. So really, it is the RV which is single-handedly handling most of the circulation. So overall epidemiology, how frequent are these problems? You can see there are some registries that talk about, say, approximately 50 cases per million. And if you get into the details, the hypoplastic left heart syndrome may be like anywhere between 2 to 2.5 cases per 10,000 live births. Tricuspid atresia is about one half of that, about one case per 10,000 live births. Okay, so why is it that certain patients, certain babies are born with it? The reasons are not entirely clear. It's probably polygenic, and but there is a higher risk to siblings and offspring of the affected individuals. In absolute terms, it's still low, but in relative terms, it is higher than the normal population. Okay, so what determines the physiology in patients born with, say, single ventricle? Now, who gets into cardiac failure? Who becomes very blue? Who actually survives without the need for any operation? Actually, we have quite a number of anecdotal reports of patients surviving and not having come to light at all, and having been diagnosed in when they were 50, 60 years, and they were just fine with what they were born. They managed, that's because of various degrees of stenosis that protected the pulmonary bed. So there are a lot of determinants, anatomical, that sort of like actually determine how the patients progress. Among them, you have to remember it could be obstruction to the inflow and outflow of the single ventricle. Say, for example, in one case, to give you an example, although in this diagram shows pulmonary artery and aorta open, what if this patient's pulmonary artery is blocked? Then this patient will be born blue, right? So you would think we have to find a way to increase his flow. But what if the opposite happens? If the patient has no pulmonary stenosis at all, then because the resistance is lower on the pulmonary side, he is going to get into failure. Then you need to band the patient. So, so the patient's clinical manifestations then depend upon a number of factors. As I mentioned here, obstruction to the inflows, outflows, then systemic and pulmonary venous return, whether there's any obstruction on the pattern, the way they're returning. Then it's important, like in any of the cases, to know the ratio of the pulmonary and systemic resistances. Normally, as we all know, the pulmonary resistance is much lower than the systemic resistance. But whether that can change with uncontrolled pulmonary blood flow, yes, patients can ischemic even with single ventricle, and so they may become bluer. Initially, those who were in cardiac failure may slowly turn blue. And then, of course, AV valve regurgitation. If first of all you have a single pump and that's handling a lot of cardiac output, and if AV valve regurgitation sets in, that's not good for the patients. Then the pump begins to fail. So now those are meant to be like broad strokes. Now I don't want you to worry about, you know, as to how we are going to manage all this. I'm going to get into the details, but just know that this is an important slide and that will determine specific individualized treatment. Okay, so let's take what happens in hypoplastic left heart physiology. In hypoplastic left heart, as I mentioned, here you can see there's a small diminutive left side. All the blood is crossing over into the right ventricle that then distributes the blood flow into both the systemic and the pulmonary bed. Then tricuspid atresia physiology, I told you to think about it the opposite way, where the blood now obligatorily has to cross from right to left, but again, once again mixes and gets distributed. Now, in both these cases, things that can change the distribution of blood are the same four factors that are referred to: AV valve regurgitation, obstruction to any of these inflows, and then say a restrictive atrial septum, and the resistances. All those are important. Now, we know what I've given you a brief introduction to what single ventricle means. And I also told you that mere presence of two ventricles does not mean that a patient will have two ventricle circulation. That is fundamental to understanding this topic. And I also gave you an idea of the morphology. We discussed the different types and the factors that can change the blood flow or the pattern in a single ventricle patient. Now we will digress for some time and then generally talk about operations, and then we will link those two together, okay, on how to manage. So we'll take a break from single ventricle and we'll just talk about some of the operations that have evolved in from the beginning. So now the Blalock toxic shunt, as you all know, was actually described for tetralogy of Fallot, pulmonary stenosis, right, or atresia, and it was described. The original concept came from Dr. Helen Taussig. It was her idea. She took this idea to Dr. Alfred Blalock and Vivian Thomas, and they devised this operation and successfully used it at to treat a number of kids who were presenting with um, cyanosis, desaturations, and spells. And in 1945, there was no treatment for tetralogy of Fallot, and the only operation at that point was the Blalock Taussig shunt. And initially, they did what is called as the classic shunt, where they turned down the subclavian artery and hooked it on to the, this is the one, picture A, and hooked it on to the right pulmonary artery. And then with time, Dr. Delival described the use of the Cortex graft, and we now use the term modified PT shunt. But what you need to understand here is that this operation was initially described for patients with two ventricles and who were blue and from having insufficient pulmonary blood flow. So we learned in 1945 that we learned how to manage patients who had insufficient pulmonary blood flow, and that answer was to create a shunt. Of course, many different types of shunts have emerged since then. We have central shunt, and even before that came the Waterston shunt, the Port shunt. I will not get into the details because of the scope of the talk that I have, but just know shunt is a way of a systemic pulmonary shunt. That's a broad term, is a way of increasing pulmonary blood flow in patients with decreased pulmonary blood flow. Then there is an opposite situation where you have excessive pulmonary blood flow, too much blood flow, and then patients get into heart failure. How do we manage that? Thanks to these two guys, Mueller and Damon, who described the pulmonary artery banding in 1952. So what they made it simple. Obviously, they observed that patients with pulmonary stenosis don't have, they seem to either have balanced or decreased blood flow. So they just mimic the situation, and using various materials have been used to cause the pulmonary stenosis. They used an external band, as you can see here, and we use muslin tape here. So people have described the use of, Cortex tubes, Cortex material, pericardium, etc. But the essence of the whole operation is to cause a narrowing in the main pulmonary artery that will cause a sort of like act like a mechanical blockade to the pulmonary blood flow, correct? So now, so 7 years later, we now learned how to manage patients with excessive pulmonary blood flow, correct? Now, meanwhile, there were some people trying to think, how can we manage single ventricles? You know, maybe is there a way we can septate them by creating some sort of like a septum? So attempts were made, initial attempt Mayo Clinic described in 1956, but this was not very successful because, first of all, the material that you use, it separates the chambers, but it does not contribute to any of the contractility itself. It is an artificial, like it could be pericardium, Gore-Tex. You could choose the material you want, but it's really not contractile. There's a high incidence of heart block. Occasionally, you can, you know, hurt one of the either the semilunar valve or the AV valves. And, this really can be used only for a select group of patients with certain specific anatomy. So it really didn't pave the way for management of single ventricles. Then, but I think personally the real big step towards management of single ventricle came from this paper in 1943. So Dr. Isaac Starr, he was doing experiments on dogs, and they were trying to create a model of acute pulmonary edema by damaging the left ventricle. So they were trying to study pulmonary edema in dogs. So how were they doing that? They were actually damaging the left coronary artery. But during their experiments, doing accidentally in one of the experiments, they injured the right coronary artery. And they found that the right ventricle, although the right ventricle infarcted, the dogs survived. Now, to them, this was amazing because we always had this mindset that both ventricles were necessary. Nature kept them, God kept them, so both ventricles were absolutely necessary. And so if left ventricle was buzzed or destroyed, patient would suffer acute pulmonary edema and die immediately. So in fact, they were studying that, but when they did hurt the right ventricle and infarcted, the dogs still survived. And what they learned through that was they came to this conclusion that you could that mammals could actually survive without a subpulmonary ventricle. This is what their initial experiments show. You can see here they've written the injection of silver nitrate into the RV wall, but RV was damaged, but the animals still survived. Then further experiments built upon this idea by Rodberg and Wagner, and they once again this was an extension of the experiments that Dr. Isaac Starr had done, and this idea progressed, and they realized that the push that came from the arterial side, what we call as visa turgo, was enough for the venous blood to get into the lungs without the need for a ventricle. So basically, now we suddenly want have a bold statement to make that ventricular pump is not mandatory for pulmonary circulation. So it's like, then why has nature kept it? Why has God kept that? We will come back to it later. But what we know now is that you don't need a ventricle, a subpulmonary ventricle, to for the animal to survive, for the blood to get into the pulmonary system. The blood was still flowing. So meanwhile, other studies were also happening, other advances in surgery. For example, here is the the azygous flow principle that was coming through, and the early inroads into the development of the Glenn circulation. And once again, they made the same conclusions that venous blood returned to the right side of the heart because of viscertal and thoracic suction during respiratory movements rather than the actions of the right atrium, right? So the idea is progressing at this point. People are learning that you don't need neither the right atrium nor the right ventricle. And then meanwhile, Dr. William Glenn describes the Glenn operation. What they do is that they divert the SVC blood. This is an older version of the classic Glenn operation that you can see here, where the right pulmonary artery is actually anastomosed to the SVC in an end-to-side manner through a right thoracotomy, and the distal part of the SVC is tied. So this is like a unidirectional Glenn operation because the entire SVC comes only into the right pulmonary artery. That is why we use the term BDG, bilateral directional Glenn, because the modern version, in the modern version of the Glenn operation, the SVC blood goes into both sides of the lungs, into both lungs, correct? So, but the people at this point of time were learning that SVC blood could be diverted into the right lung, and it was able to flow without the need for any pump. So they're like, So what Isaac, Starr about the um, the fact that the RV is not dispensable was turning out to be true. We were able to now divert SVC return into the lungs, and patients were actually getting better. The cyanosis, though, was not completely treated. They were able to get the oxygen saturations into the 80s, and patients were doing fine. Then they came out with their first series of successful Glen. But of course, we all know now the Glen is now modified. Dogliotti and others describe the modern version where you can see why it's called the term bidirectional is because it flows into both lungs. We do it in an end-to-side manner, and typically, um, various ways of doing this have been described. Once again, I won't get into the details, but you need to understand the broad principles of surgery at this point. So now we know how to divert SVC blood into both the lungs without the need for a ventricle. At this point, I will just stop and make this important point that both Glenn and shunt operations increase oxygen saturation. No doubt, right? In both cases, patient's oxygen saturation will rise to sustainable levels where the patients can actually function reasonably. May not be able to run a marathon, but they can carry on with all their life's activities. But you can see in a Glen, the SVC is hooked directly onto the pulmonary artery, whereas in a BT shunt, it is the mixed blood that is being once again diverted into the um, pulmonary artery. But the essential difference exists between the two. Although both cause increase in oxygen saturations, the Glen does so without increasing volume load on the ventricle. That's the huge advantage of the Glen operation, which means that if you look at this picture here, this return would have normally gone into the ventricle. What we do is we just cut this and now let it flow through the pulmonary arteries before it comes back. So the volume load on the single ventricle does not increase. If anything, actually, when you convert a patient from BT shunt to Glen, there is volume offloading of the ventricle. The heart loves a Glen operation. The heart does not like BT shunt so much, but the heart in general withstands a Glen operation very well because you volume offload and you increase the oxygen saturations to the same level as a BT shunt, but with less stress on the heart. Okay, so that one again, you have to understand these principles of Glen, Fontan, of Glen and BT shunt before we proceed on to the Fontan. Then in 1971, there was a landmark paper by Dr. Francis Fontan and his group where they suddenly found a way to transmit the inferior vena cava blood to the lungs. Because now we are building upon ideas. First idea was we don't need a supplementary ventricle. Then we learned that we can now transmit the SVC blood because Dr. William Glenn showed that how to do it. Now, this is great news. Patient saturations have now risen to 80s, but now people want it to be like 100. They want these patients to function even better. So now they're asking, how can we send the IVC blood? Because they know that the patients don't need ventricle to send IVC blood because of the experiments done in 1950s, correct? So what they do is there is now a lot of attempts being made, and Francis Fontan and you will see here Dr. Kreutzner from Brazil, they succeed in establishing this pathway. Both get credit because it was around the same time that both of them succeeded. Francis Fontaine described this modification because what he did was he just closed the ASD here and then connected this directly into the left lung. So the right lung receives all the blue blood from the upper half of the body, and the left lung receives all the blue blood from the lower part of the body. That's great. And our patients are fully saturated, and everybody's rejoicing. This comes the great operation that has solved our problems with single ventricle. And this is Dr. Kreutzner who described his version of the same operation, except that what he thought was, why even connect the SVC there? Connect SVC, IVC, everything through one tubing into thing. So now you will see there are different versions of this concept appearing. People gave them their own names. It doesn't matter. In fact, people try to interpose a valve so that there is no leak, but that wasn't very successful because the valve caused losses of energy, right? So people stopped putting valves after a certain time. And Dr. York also described his own version by using a trans AV group patch on the top. This is all, remember, all these operations are being described for tricuspid atresia at this point, which is until now, we don't have treatment for hyperplast left heart syndrome. Treatment for hyperplast left heart syndrome came only in the 1980s. So all these versions that you're seeing, you have to think only of tricuspid atresia at this point. So that is how we evolved. So we know now that tricuspid atresia can receive Glenn, and then they can receive Fontan. And so all these pictures that you see are focused on tricuspid atresia. Because until now, the hyperplast left heart, we have no treatment, we're letting those babies die. Okay. And then comes the modified Fontan procedure. Like, you know, like I was saying, Dr. Donald Doughty, they were, everybody had their own different versions. You can see here, he has a way of doing his connection. It doesn't matter. But they all achieved the same end result. Okay, I'm just giving you some examples of how people were doing their own Danielson's, and Danielson himself described a different version in 1980. And now the next big breakthrough in management of single ventricles comes in 1980s when Dr. William Norwood describes the treatment for hyperplast left heart syndrome. So now that comes as a shot in the arm for the world of pediatric cardiothoracic surgery because we knew how to manage tricuspid atresia, which is a right-sided problem, but you have a dominant left ventricle. But we didn't know how to manage a left-sided AV problem with dominant right ventricle. So now this, until then, the babies were, they had no operation and they were basically allowed to die, and some attempts were being made at neonatal heart transplantation for those babies. But once again, the progress had not been great. So at this point, Dr. Norwood describes the first successful um, surgical management of HLHS. And this is the paper that quoted him. You can see here. And you can see here, this is a picture from that article that describes how he managed this patient. So you can see here, in fact, what is interesting is if you read this paper, he originally described an RV to PA conduit as a source of pulmonary blood flow. Later iterations focused on BTT shunt as source of pulmonary blood flow. But you can see in the original paper, it was actually an RV to PA conduit. But then you can see here the orbit operation as we do today. Once again, my focus for students is on concepts. It's not to get into the details of operations that you will learn as residents and at the appropriate time. But right now, I'll just give you a brief idea of what we do is that the the crux of the whole operation, right, is to use a pulmonary valve, is to convert that into an aortic valve. That's what we are doing by joining the diminutive aorta to the pulmonary artery and creating an unobstructed systemic venous pathway. So we gave the systemic arterial pathway, sorry. So what we're doing here is basically join the aorta to the pulmonary artery, converting the pulmonary valve to like an aortic valve, and then augmenting the entire systemic outflow tract, thereby creating an unobstructed systemic outflow tract. Then also to make sure you create an unobstructed DKS. DKS refers to the joining of ascending aorta and the pulmonary artery. That way there is no obstruction to the coronary blood flow. Then you also want to make sure there is some source of pulmonary blood flow, either in the form of BTT shunt or, depending upon the group, people who believe in the SANO, which is an RV to be a conduit. So one of those two as a source of pulmonary blood flow. You also want to make sure that the AV valve is functioning fine and through the entire operation that the myocardium is well preserved. So those are the goals of the Norwood operation. So now of course, Dr. Suji Sano from Japan described the RV to PA conduit as a source of colon blood flow. And a lot of institutions use RV to PA conduit as against a BTD shunt because most of us believe that the interstate survival is enhanced, especially in the early postoperative period, with usage of an RV to PA conduit rather than a BTT shunt. So at our institution also, Dr. Ralph Mosca and I, we both use a Sano as a source of colon blood flow, and we generally use a 5 millimeter ringed cortex graft, use a dunking technique, what we call as a periscopic technique, and described from NYU. And then we use that as source of colon blood flow and then convert to a hemifontan at stage 2 of the game. So by now, we have started making inroads into hyperplast left heart. We have suddenly attacked one of the most common forms of single ventricle, and which we didn't have a management plan until now. So we know how to do the Norwood operation. But then modifications started, but there were no description of operations for how to convert this to the stage 2 and stage 3, right? And so papers started appearing on how to modify the Fontan operation for patients with left AV valve atresia. So Francisco Puga started describing his way of doing it, and you can see here at this point, um, you know, um, tunneled pathways are being created, and the same principle, right? It's the same principle, except that the anatomy is slightly different. But what we are achieving is to divert the entire systemic venous flow into the PA, and converting the only pump that the patient has into a systemic pump, correct? So that's the goals of the single ventricle. And so early papers are now coming on describing that. But Dr. Mark Delival at Great Ormond Street, not only a great surgeon but a great thinker, who was while he was doing his experiments on the single ventricle, realized that there was a loss of energy when atriopulmonary connections were being performed, meaning like, and he described what is called as the total cavopulmonary connection. In the total cavopulmonary connection, what they're doing is that instead of using the entire atrium to channel the IVC blood, they are just using tubes. And the tubes in the form of, say, cortex tubes or pericardial tubes, whatever, they maintain the laminar flow from the IVC into the pulmonary artery and thereby prevented losses of energy. If you take laminar flow and put it into a baggy, like a chamber, what happens is there is loss of energy and the atrium enlarges. And then by the time the blood flow gets into the pulmonary artery, the vis ergo is already reduced. So what he said was that we need to create straight channels. And that introduced the concept of the total cavopulmonary connections, right? So you can see here, now that, see, it's interesting how surgery evolves from one aspect and keeps going through iterations until we get into finer and finer parts. So then Dr. Carlo Marcelletti from Italy described the extracardiac operation. What he did was he was like, why use the right atrium at all? Then just put a Gore-Tex tube from the IVC straight into the SVC and then be done with the atrium. Because one of the problems we were facing was that when the atrium was being used, there were a lot of suture lines on the atrium, and that was giving rise to arrhythmias. So he said, why don't we just use a Gore-Tex tube? And the patients did not need, they just ended up with small doses of either coumadin or aspirin. Really, the clotting was not a problem. And so the extracardiac Fontan became a popular way of doing this Fontan, right? So we have now evolved from atriopulmonary connections to total cavopulmonary, and a form of that is really an extracardiac operation, right? And then this paper from Boston is important because people realize the advantage of creating a fenestration within the conduit. They realize that taking the splanchnic pressure or the systemic venous pressure suddenly up from single digits to double digits was not so good for the body. So they created a fenestration, and the fenestration in a way decreased the Fontan pressures to a certain extent and ensure cardiac output. And so the advantages of baffle fenestration were realized. And so at our center also we create fenestrations in the baffle pathway. We do what is called as extracardiac technique. And in the intracardiac portion, we create a 3 millimeter opening. And you know, there is a debate about the advantages and disadvantages of this, but we generally find it to be very useful. And definitely, we find that the incidence of pleural effusions is much lower. So that's the reason why a lot of the surgical groups create fenestrations in the baffle. So now you understand once again how surgery has evolved, and now conduits are being fenestrated at this point, right? So Castaneda's own version, and then no matter what of Fontaine you did, people were trying to find a way to create a side hole that could sort of like went directly into the common atrium. But a very important paper, and a very commonly asked questions by the medical students and like cardiac surgeons and fellows who follow me are, why is the Fontan operation done in two stages? Why don't we do the whole thing in one stage? Now, I would refer you all to this paper, once again by Dr. Norwood and Marshall Jacobs, where they found that, look at this, patients who have Fontan in one stage do much worse than patients who get Fontan in a staged manner. That is because that's got to do with ventricular remodeling. And once again, I cannot get into the details of how that, but when you suddenly offload the ventricle, but the ventricular mass volume ratio has not been optimized, the end diastolic pressures tend to become high, and the patients tend to become very edematous and anasarchic. They may survive, but the length of hospital stay, the duration on ventilator, everything is significantly more. So what we learned was when the group of patients who had this in stages, they seem to do much better. So that is why we try to separate out the stage 2 from stage 3. We give it a couple of years and allow the ventricle to remodel and then subject it to Fontan. And then you can see that operation goes very smooth. Patients are discharged by day 5, day 6. And they really, it's like a simple open heart surgery. So this is a landmark paper that will explain to you in detail why their observations and explain why the Norwood operation was done in two stages. I mean, the Fontan operation. So now, at this point, um, I just want to tell you an important thing that Dr. Fontan had made, an observation that Dr. Fontan had made when he described the Fontan operation. He always said that the he was worried about the atrial arrhythmias because he realized that there were a lot of suture lines. And so one of the problems associated with atriopulmonary Fontan, as it was done in those days, was the suture burden and the propensity for the atria to dilate. Because remember, we were doing, before we realized the advantages of the laminar pathway, we created this baggy atrium that set the patients for arrhythmias, right? And so that is why many of these older connections have been taken down and converted into lateral tunnel pathways, right? Or total cavopulmonary connections. That is why you will see Fontan conversion. The term Fontan conversion refers to conversion of old style atrial pulmonary to what I would call as total pulmonary using extracardiac or intra-extra, whatever technique, right? But that has become a less frequent operation because most surgeons have now embraced total pulmonary connections. So you can see here in the 1990s and 2000, there were a lot of conversions. And for the students, I want you to understand the reason for the conversion was because of the high incidence of arrhythmias. And you could also say there was a higher incidence of Fontan failure from the stagnation of the blood itself. Then here is Dr. Hillel Lax describing, conversion of atrial to cavopulmonary and management of arrhythmias. So you can see here, this is an old style Fontan that's now converted into the modulative conversion that I described to you. So this is what a Fontan conversion looks like. In addition, we do maze operation, which is like basically a surgery to treat arrhythmias. Okay, so this is Fontan conversion. So you can see here another paper from this group described Dr. Konstantin Mavridis and Dr. Karlbacher. They describe one of the largest series of total pulmonary conversion and maze procedure for patients with failure of the Fontan operation. Okay, so now I'll just get into make a brief mention of what are called as Chaucer's commandments, which means that to take a patient with single ventricle to Fontan procedure, he described 10 different rules. For example, he said patient should be greater than 4 years, should be have a good rhythm, normal systemic venous drainage, RA should be okay, mean artery, pulmonary artery pressure should be less than 15. That means the pulmonary artery as a protected bed, PVR of less than 4. He even described the size of the pulmonary artery. He wanted stressed on the importance of having good sized branch pulmonary arteries, normal ventricular function, competent FTV valve. Remember, all these are being described mainly in the scenario of tricuspid atresia. But over the years, we have learned that many of those stringent criteria have disappeared, and we have focused more and more on pulmonary artery pressure being less or around 15, resistance preferably being less than 3 to 4 Wood units, pulmonary artery being decent size, normal systemic ventricular function, and a competent valve. Now that has got further refined, and we have now come to realize that among the most two important factors for a patient to have a successful Fontan, he should have good systemic ventricular function, which also means that his EDP or end diastolic filling pressure should be good, and the mean artery pressures should be less than 15 millimeters of mercury. So finally, because we can manage arrhythmias, because we have pacemakers, we can manage pulmonary artery size, we can enlarge them by using, pulmonary homographs. So we can manage a lot of the about the age being 4 years is not entirely true. It's the physiology which dictates rather than the age. So at the end of it, we learned to realize what are important, what are not. And finally, we learned that among the many factors that were originally described, the most important are the function and the PA pressures. Okay. And then you also have different versions of the extracardiac. People have described the use of a rolled pericardial tube. A pericardium in situ, you can see here, has been harvested and rolled into sort of like a tube. So there are many ways to do this operation. And then there's a pedicled tube. And this is from my previous institution where I was the assistant professor with Dr. Christopher Nordcraig, and we described the importance of vasopressin after Fontan operation. I just put this up because, this came from our group, and as my knowledge goes, this being increasingly used at many institutions for to control the pleural effusions and the hospital length of stay after the Fontan operations. So that article is published in the World Journal. Now, how do we? I'm going to give you a short summary of the entire Fontan circulation. After we are describing all this, let's rehash the whole thing once again. So management of univentricular heart. What is the ultimate step? We want to achieve a Fontan circulation. So, but meanwhile, how do we go through that? Relieve cyanosis, but protect the pulmonary vascular bed, which means don't allow too much blood flow because that will incite development of PVR issues. Adequate systemic perfusion is important and present also preserve the ventricle. So preserve the ventricle, preserve the pulmonary bed. So how do we approach this in stages? When a child is born, because we don't know what's happening, start prostins until ductus presence or absence is ruled out. If the atrial septum is restrictive, do a balloon atrial septostomy. It's not very frequently needed, but if needed, here are the fundamental principles. When you have single ventricle and decreased blood flow, to the extent that the child cannot maintain saturations without oxygen, do a shunt. That's all I want the group to go back home. The important messages are single ventricle, blue baby, do a shunt operation. Single ventricle, increased blood flow, do a band. Because if you don't do a band, the pulmonary blood will flow torrentially and cause development of PVR and patient will lose candidacy for single ventricle, correct? And what do you do in a unique situation of hyperplast where you have increased pulmonary blood flow, but also obstruction to the aortic flow, right? That's the only situation that really is a Norwood operation, to be honest with you. Rarely ever you see that. It's a hyperplast left heart. Sorry. And for that, what do we do? A Norwood DKS. So, as a surgeon, to those who want to become pediatric cardiac surgeons out there, just know BT shunt has its place, PA band, Norwood. These will be it will be one of these three steps, right? During the neonatal period. I hope this is clear. Then what do we do is if there is also important to pay attention to these things is medical management. If suppose this shunt is oversized or your band is undersized, control the heart failure, see this management beyond the neonatal period, and look out for any of these bad things happening. If they say recurrent obstruction, the aortic arch you have constructed, send back to cath lab. If the pulmonary arteries are not looking good, get an angioplasty done. Make sure the valve, that's why we have our cardiologists following these patients frequently with echo, making sure that none of these bad things are happening. Then you take the patient through the neonatal period. Actually, we send them home. They're gaining weight. They're being monitored, using home monitoring program, interstage home monitoring program. Parents actually go with, a pulse oximeter, and our NPs call them every week or once in 2 weeks, check on them, ask them how is the weight gain, what are the oxygen saturations of the child, how is the child doing. So by the time they come back to us 4 to 6 months, we have this now patient gone from the stage of a neonate to a child who is about 5 to 6 kilos in weight. Generally, at least 6 kilos, I would say. Many of the patients tend to have gained decent amount of weight. Their oxygen saturations at this point are now beginning to dip because either the band is getting tight. Remember, band doesn't grow with the patient, or the shunt doesn't grow with the patient. So what is happening? Or the sano doesn't grow with the patient. So they are now outgrowing these things, and patients need something else to keep up with to increase their demand, to keep up with their increased demands. So now is this time we send them to cath lab, make sure patients are favorable candidates, which means that what did I tell you? Two important factors that the ventricular function and the EDPs are good. Second thing is pulmonary vascular resistance. That is the PA pressures are less than say 50. Okay, if those two things are good, then you know this patient is going to be a successful candidate or it's a good candidate for next stage of the operation. And so at our institution, we do about hemifontan, about 50% of the patients can get hemifontan and 50% of the patients get Glen. Once again, I will not go into the details of what determines the difference. It's not needed. We can talk about this at a different setting, but just know both of them achieve the same physiology. That is, the SVC blood is directed into the pulmonary arteries. They're just two different designs. Okay, one has set up to achieve a more favorable third operation, whereas the other one is a simpler operation. Now, what do we do after the Glen is done? Patients go home. Remember, I told you doing Glen and Fontan at the same stage is not a good idea, right? That is why we send them home, because we learned in the 1980s and 90s that, and they were both done at the same point, the patients, the heart is not yet remodeled, the ventricular mass volume ratio changes, and patients need to do not as well. So we send them home and get them back at 2.5, 3 years. I tend to wait until 3.5 years. There is no rush really. And because once you do the Fontan procedure, this oxygen saturations become normal, like any of us. But then I also worry about the fact that the liver starts bearing the pressure. So that is why it's my own personal preference to wait until 3 years of age. And remember, doing this surgical management, if there's any outflow tract obstruction in between, if the AV valve is leaking, repair that. And if has atrial level obstruction, either balloon it or do an atrial sepectomy. So great. So should we be patting ourselves on the back saying, oh my God, we have found it all. We have found the solution to patients with single ventricle. So did we hit the target? Or, did we actually create a problem? Right? So how are the patients doing so far? Let's examine out our own some of the results. Okay. BT shunt, this was some of the old reports. Okay. The reports these days are much better. So meaning like with a normal BT shunt, overall survival, either with BT or Sano, the overall national results show survival of 85 to 90% of these patients improve, right? And I have described the advantages of the Sano. Once again, we don't have to get into the details of that, but a number of institutions do the Sano modification. Then, so we have about 85-90% of the patients surviving stage one. What happens at stage two? Look at the hospital mortality for stage two. It is very, very low. So now that 90% is still around 90, maybe 88%. Then what happens to these patients once they come to the stage of the Fontan operation? Let's look at the results, and you can see here, sometimes we have to take down these Fontans when they don't like the physiology. It's very rare, to be honest, in selected patients, because we really subject them to cath tests and anything before taking them to Fontan. But even here, you can see that these are the early results, right? But if you look at the more recent results, you can see that the survival is impressive. Most of these patients survive Fontan procedure. It's true that some of them are not candidates for Fontan. That's rare, but most of these patients tend to survive. And you can look at even the incidence of arrhythmias, right? It's about 5.5%. You can further break them into SVT and bradyarrhythmias. But the problem is that many of these tend to get worse with time. But you can see overall, there is nearly you can say at 15 years follow-up for a Fontan, there is 85% survival, which means that 15% of the patients are lost at 15 years of follow-up, right? That's the easy way of thinking about it. But look at the impressive results from different groups. I just put up the slides for you all to see, and the results from various groups are all very, very good. And some of these are older papers. More modern papers show even more impressive results, right? You can see, for example, here from Isui from Japan, is described different procedures in the Fontan here, right? And then see, there are no operative deaths at all, no Fontan failure, even at follow-up, late follow-up. So this they describes only up to 5 years, but we have data coming out from Australia and New Zealand registry, from the US registry, that shows that overall survival is excellent. So what about the functional status? um, it actually is quite impressive. I have seen patients being actively engaged in sports, you know, and you can see this. They tend to have reasonable exercise tolerance, and sometimes you can't even identify that They are cardiac patients. Most patients needs have cognitive outcomes that are within normal range. And single ventricle patients, it is true that they have a higher incidence of coagulation disorders, but if anybody has shows that they have, we manage them with anticoagulation. Rhythm disturbances do tend to become more common as we follow patients later into their operations. And but overall, you can see that if you look here, factor surviving, it is the patient selection that matters most, which means that you have to prepare the patients, band them when necessary, shunt them when necessary, correct the outflow tract obstruction, correct the AV valve regurgitation. So all that has led to more and more and more survival. So now I could say that anybody born with single ventricle at 15 or 20 years of age, if you look at them, you can say in excess of 80% they make it and they're surviving at 15 to 20 years of age. But we all know, we keep being reminded of this as surgeons, patient survival does not mean that your operation is successful. That alone is not enough, right? So what else are we talking about? What am I referring to is the quality of life. Let's see what a Fontan achieves. Fontan alleviates hypoxia. It removes the volume overload of the single ventricle, achieves balanced pulmonary and systemic circulation. It improves single ventricle natural history, no doubt about that. Left to itself, single ventricles otherwise have really abysmal outlooks. It does all this. That's great. It improves the quality of life to a certain extent. But look at what Fontan himself wrote in his paper when he first started describing. He described, if you look at the curve, at 15 years, we can see about approximately it is 15 to 20% of the patients, they begin to have attrition in the form of, like, say, mortality, you know, failures, etc. So this is the early series you can see here, right? And but generally at 15 years, the more contemporary series show is a 15% attrition. But that was originally predicted by Fontan himself. So why does the Fontan begin to fail? After we created this wonderful circulation, patients are now in their college. I know patients who are studying in their college now, they're doing very well at school. But then if they get into their 30s, we begin to see issues. Ventricular dysfunction begins to set in. Systemic complications of Fontan physiology. Various terms are used, chronic Fontan failure. And if we get into each of these, to be honest with you, we don't know the exact mechanism. There are various theories. Ventricular dysfunction itself, we don't know why it sets in. Is it because if it is not receiving enough volume, or is it because patients have collaterals and causes overload? We don't know the exact treatment. I mean, the exact etiology. But yes, we can manage them to a certain extent with the use of certain medications. Then a certain number of these patients begin to develop protein losing enteropathy, right? So you will see that they they begin to lose proteins in their intestinal lumen and through feces, and then you see the level of proteins in general in the body, including immunoglobulins, everything else begins to go down. And then survival, once the PLE is diagnosed, is generally bad news, right? And it's the problem is that we are not able to decipher what is it that leads to PLE. For example, patients with high Fontan pressure sometimes they do just well, and sometimes patients with low Fontan pressures develop PLE. So it is not the Fontan pressure. Is it abnormal lymphatics? So at CHOP, a lot of work has been done on this, and so we are learning more and more about this. And CHOP has led the progress in this area. And so they do try and plug some of those lymphatics, and some of them actually patients go on to do well. But in general, once you have refractory PLE, you begin to think of transplantation at this point. Now it can become a huge issue. Then you can have plastic bronchitis, same thing manifesting in the lungs. This is an actual cast of a patient who is just, it's been removed through bronchoscopy. You can see the CAS taking the exact shape of the airway. Then, of course, you have chronic Fontan failure where patients begin to develop chronic low cardiac output, exercise capacity goes down, and then it's said it continues to fall at a rate of approximately 2.6% predicted per year. Then, so we are asking, where did we go wrong as a community? What happened? So, if you think about it, you will see that all these mammals, amphibians, fish, all the circulatory system evolved over millions and millions of years, right? You take any species, even mammals, it took 200 million years. And there was a selection based that nature selected out those who survived, and gradually the system evolved. And the systemic, and even in fish, right? It's all in series. But what did we do? When we created the Fontan circulation, we created a circulation that was hitherto unknown to nature. We created this as a man-made circulation that does not mimic any animal. Okay, so we created this for the first time. And how old is the Fontan? 40 years compared to 200 million years that we have. So that is why it will we have to acknowledge that this is likely to have problems, right? So now I will explain this through these curves, very easy to understand. This is a landmark paper, Gevlich, that described. Now let's take normal circulation, right? You can see here the pressure in the aorta is higher, and then as it comes towards the veins, right, the RF pressure is really low at this point. Then this jump happens here. This second jump happens because of the subpulmonary ventricle, that is the right ventricle. Now we are realizing, oh, I got kept a ventricle there under the lungs, right? The subpulmonary ventricle, because we were quick to celebrate and say that the ventricle is not needed. That was what Isaac Starr said in 1950s. And now, 50 years later, we are drawing these curves and we're eating the humble pie and learning that, look, this is what the advantage of the subpulmonary ventricle was. If you notice here, the RA pressure is lower than the LA pressure, correct? You see, it comes below the baseline. Again, gets pumped into the pulmonary artery, goes into makes its way through the lungs into the LA, and then gets pumped by the aorta. So this we all learned from medical school. What happens in univentricular hearts, right? In univentricular hearts, RA and LA are the same. That's why we use the term common atrium, correct? And what about the pressures? The pressures in the pulmonary and systemic are the same, right? Because this is a case where, of course, it's an unpalliated, right? No PS, no, that's why. So that is why the curve shows this. But the blood comes back here and once again gets pumped into the aorta and the pulmonary artery. Here, correct. There's no doubt about that. Now, this we know does not have a favorable prognosis. So we changed this because we couldn't convert it to this, we changed it into this. What this Fontaine create here is that here you have systemic and pulmonary circulation in series. Yes, it achieved a lot of things, right? It reduced the volume load, it increases saturations. But look what happens here is where the tricky part appears. That the blood, the pressure in the RA now has to be higher than the pressure in the LA for it to flow. Whereas here, see, the RA pressure is lower than the LA because there's a pump to take over the function. But look here, the RA pressure of necessity has to be higher than the LA because they're connected in series, right? So that is called as the Fontan paradox, which means that the normal pulmonary artery pressure is greater than 50 opening pressure. To have a good Fontan, meaning like Hence, a good Fontan, what they're saying is that if you keep the pressure so low, you'll have poor lung perfusion. So if you want to have optimum pulmonary perfusion, that can happen only by definition when the RA pressures are high, right? Meaning like you can get forward output only at the expense of congestion on the right side. So we are causing liver congestion. That's exactly why patient's liver begins to fail. Begin to develop cirrhosis. That's exactly why your splanchnic bed begins to complain and develops plus all this PLE, right? And so those are manifestations of chronic congestion, right? But if you don't have that, if you don't build that congestion, then the blood cannot flow. So that is why we are caught in this paradox, right? So now this is a flow chart that shows the decremental effects of increased CVP, right? It's ranging from hepatic cirrhosis to bronchial casts, and it shows, in a way, there are many different types of chart, but that explains the physiology, the man-made physiology that we created by doing the Fontan operation. So how do we manage this? So when we put a patient under the blade and create a Fontan, what can we expect? Straight away, we can expect systemic venous hypertension. If you notice, Fontan patients, they don't like to eat the first week of after surgery. You go see a patient and then the nurse practitioner, the nurse will tell you, Dr. Kumar, the child is not feeding. And I tell them, is that a surprise? Because now the gut and the liver are congested. So it takes a certain time for them to get adapted to this new pressures and learn to eat and digest. On the other hand, you go walk towards a Glenn patient. You notice after Glenn, the head is swollen. The parents say, oh, my child's eyelids look swollen, but that will get better with time. But the same thing, swelling is now happening in the abdomen that you can't see when you created the Fontan circulation, correct? So that's the easiest way to think about it. So those are expected things. So you caused systemic venous hypertension, no matter how much you diurese, right? You cannot make it normal. Because like I said, if you make it normal, you won't have forward outflow in the pulmonary pathway. So your pulmonary blood flow will decrease. So it's a necessary evil now at this point. Arrhythmias you can expect. No matter how great a job you do, how much MIMS you just report, increased pulmonary impedance. It's interesting that when the ventricle is taken away and the pulsatility is lost in the pulmonary artery pathway, those pulmonary arteries tend to develop increased resistance as the flow goes away from pulsatility to continuous flow, right? When the ventricle was there, it was imparting pulsatility. Now the ventricle doesn't exist anymore. GI malabsorption, PLE, so if the patient is out there 10 years later of Fontan, comes to your office, and I ask him, how are you doing? He says, great. And very subtly, I'm asking them, oh, what do you eat, etc. Just to make sure. He says, oh, I'm great. I eat everything. I'm so happy because I know he isn't developed PLE, right? I can't ask the patient, do you have PLE? But I'm like, how are you doing? How do you go to the gym? Do you go to the exercise? What's your favorite food? So that's the way I'm trying to make sure that patients are okay. Because once PLE sets in, it's not great news. Deteriorating ventricular function. We look at echo, we follow them up. Not everybody develops all these problems. I want you to understand. I don't want you to go home with the wrong message, with a very dismal picture of all that we have achieved. I'm trying to highlight the problems and challenges we're facing here. What we've created is a great operation. I'm not taking away the credit. We have managed to survive these patients who had no chance of survival. We are able to get them to 40 years of age now. The challenges that I'm highlighting here are what do we do 40 years onwards, right? How do we manage them? Right? Because the incidence of these problems that I'm highlighting tend to become more and more with time, right? And so we thought maybe we should go back to cath lab and fenestrate the lateral tunnel to bring the pressures down. So that has been described. Then that is one way of maybe mitigating the problem or ameliorating to a certain extent. Then people said, why do a Fontan at all? Just leave patients with bidirectional Glenn and antegrade pulmonary blood flow, then patients have saturations of 80s, 85, and then they're able to carry on with their life. And they don't need to run marathons. They don't need to compete in school sports, but they can do everything else. So why subject the liver to unwanted pressure just to get your oxygen saturation to 100, right? So there are some surgeons who truly do not believe in Fontan. Just because somebody does Fontan doesn't mean you have to do Fontan. You can tell your patient, I don't want to do the Fontan. Let's just wait and watch and do the Fontan only if become very blue, right? So and to avoid that, you also create antegrade pulmonary blood for what is called as a pulsatile gland. Once again, given the limited scope, I cannot get into the details, but that is definitely prolongs the or increase the longevity of the gland operation. So then you have no, once again, I'm just saying this advantages are it prevents AV malformations, and then patients can be managed with this as the sole therapy for a number of years. Then what about people said, we'll do the Fontan, but without the use of circulatory support, will the avoidance of, bypass machine increase our results in any way? It's not been proven. Then, so people then went to the hybrid room and they tried to do by doing this without cardiopulmonary bypass. This shows how you can potentially do the operation clamp and sew method without even a need for arresting the heart, and in some cases for without the need for a bypass machine. But and one more before I go jump is percutaneous Fontan completion has been described, which means that you do the Glennon bypass and then the Fontan is completed in the cath lab. It's been there are a number of reports coming from Middle East too, where you can see here what they do is that at the time of the a heavy fontan or the fontan, they've created a patch that can now be fenestrated using a balloon catheter, and then you can place a stent within it, a covered stent, and it will achieve the same results as the fontan. But I can tell you, it doesn't mean that these patients are exempt from fate. They suffer the same fate. So you can see this is an example of how you can do this. I had actually a patient exactly of this type that I ended up transplanting that actually came from Middle East and had a percutaneous technique and actually was failing. We ended up doing a liver and a heart liver transplant. So the my point be here being that none of these techniques is immune from failure, right? Now, what about heart transplantation following for failing? It is very, very challenging. Generally, I can tell you, I would not use the word very poor outcomes. Sorry for the exaggeration there, but I would say not as great outcomes these days compared to many other forms of things because we still struggle. They tend to have lung issues, collaterals, high PRA, they're highly sensitized because of the multiple operations they've passed. They need antibody reduction one way or the other. They tend to have rejections. The funny thing here is that patients may tend to have low DSA in the beginning and manifest rejections only when the liver begins to improve, right? And then vascular issues are a huge problem. And then the anatomy, not to mention, is highly complicated. It is one of the most challenging heart operations that you can do is do that on a failing fontan with challenging anatomy. What about the devices? They have not been a great solution. Then we have this some of these innovative techniques being described to put a ventricular-like assist device within the Fontan pathway. This was described by Dr. Mark Rutherford from Indiana, and I think it's been now, he transferred the technology to NASA, and they are working on this. So what they do is they put a viscous impeller within the Fontan pathway, and then you can see the SVC and IVC are connected, and it functions like a VAD and pushes the blood forward. So it is acting like a pump, substituting for the absence of the right ventricle. And in fact, I don't know whether I had a video of that actually. Not be able to show that. Anyway, but the Fontan operation, you can see then it was atrial now extracardiac, intracardiac, future ventricular assist devices. And heart transplantation may not be able to solve the problem, but I would put my bet on ventricular assist devices as we move forward. So, as things stand today, it's a necessary evil despite inevitable attrition. It will at some point hurt you. It would be wrong to tell a patient you will have a normal lifespan. What I tell them is that fourth, fifth decade, and then you problems will set in. But we do give them hope, saying that technology is changing, and then uh, what we may find impossible today may become possible in 5 years or 10 years time. So hopefully technology will emerge, and like I showed in that viscous impeller, we may be able to put a small pump on the right side and substitute the RV function with the device. Okay, so I'll end my talk by giving this quote, see, man's mind once stretched never regains its original dimensions. Okay, thank you guys. Okay, so that's the story of the Fontan. If you have any questions, you can ask questions.
Well, thank you, Dr. Kumar, for a really great presentation. I mean, taking us through the history of the Fontan procedure, the physiology, and all of that was tremendous, and we were very appreciative of your time.
Yeah, thank
Um,
you very much. Yeah,
at this time, I'll ask if anyone in the audience has any questions. If not, I have one or two questions to ask.
this is with Dr. Kreutzer and Dr. Um, Marshall Jacobs. So remember the hemifontan? It was described by Dr. Jacobs and Dr. Norwood. They are the ones who also described the advantage of the stage repair.
So one of my questions was actually about the stage repair. Is there ever an indication to not not do the Fontan in a stage and just do a complete Fontan from the get-go?
Um, Actually, people do it. People do not within the US. When patients, as I hear from outside countries, what they do is, but it's a very highly select group of patients. I'll give you an example. It's an 8-year-old with a balanced pulmonary blood flow. He had PS to be born with, and now he's getting blue, right? So then, 8-year-old comes into your hospital, then they have social constraints, financial constraints, and then you think, okay, let me do a Glen on this patient. But then the patients, may now not come back for Fontan. They may not have the resources. Then in those cases, especially if you think the ventricular function is good, and if your ICU capabilities are high, at that point, I would attempt one stage Fontan. But that doesn't mean that these are patients who don't need stage one. Or you know what I'm trying to say? Stage one, nature gave them stage one. What you're doing is just combining stage two and three in a select group of patients who have to be selected out very carefully. So I think they may be okay, but I still believe that it's for it's a better way of doing things is to actually stage it.
Great, thank you.
Yeah. Any more questions, guys?
No, sir, it doesn't look like it. But so we just
Relatives?
want to th say thank you from the TSMA side for coming and giving this wonderful lecture. We really appreciate you. And thank you,
Yeah.
everyone in the audience that stuck with us through this. We'll keep you posted for future webinars and events. Thank you.
Yeah. Thank you, Ahmed. Either I really did a good job because nobody has questions, or he did a bad because nobody understood. I hope, this messages here I wanted to keep were really simple, is that, medical students come and want to know about Norwood, they want to know about, extracardiac Fontan. I always tell them that you have to first be solid in basics. You have to understand why we are doing what we are doing is less important. Why is more important, why and what age? Those sort of things are what makes you good surgeons and good cardiologists. So that is why I like to talk about basics, and that is why my talk was completely focused on the philosophy of the operation rather than the operation itself. Okay. Okay. Great, guys. Thanks. Bye bye.